turnout, good level of participation, and we were pleased with how that all went. And then we got all of the information back, and we organized the responses, and we made the responses public. We put them up on our website. We put a release out, and we said, here is the result of the public consultations. Here's who we heard from, and here's what we heard. Here's what they told us. And we made it clear that we were moving forward with our plan to get fair generic drug prices for Nova Scotians. Last week, I announced the features of that plan, what it is we intend to do. And I introduced a bill here in the legislature which would allow, and the draft regulations we released as well. And we did that because we're moving forward with this plan. And we're very committed, very dedicated to getting fair drug prices. What do we think fair drug prices should look like? Well, they shouldn't be 60–70% of the brand drug, number one. We've also, in addition to the consultation that we've done, we have done our research, and we've looked at what are the policy positions of every other province in the country. We're looking at what are they doing in BC on this. You know, people in BC don't want to be any more fleeced by the generic drug companies than people in Nova Scotia, frankly. And they're doing pretty much what we're doing. Same thing with people in Alberta and in Manitoba and Saskatchewan. Saskatchewan launched their strategy last week, put it up, and they're doing pretty much what we're doing. And what these other provinces are doing, they're capping the price of generic drugs. And they're capping the price of generic drugs at 35% of brand. They're not doing it immediately, neither are we. We intend to phase that in over a year. So we have legislation here on the floor now, and our plan is that on the 1st of July of this year, we will cap the price of generic drugs in Nova Scotia at 45% of brand. And then 6 months later, in January of 12, the cap will move to 40% of brand. And then the 1st of July in 2012, we will cap the price at 35% of brand. Now, I've been asked why we didn't go to 25%, which is what Ontario did. And, you know, here I think there are lessons to be learned by really assessing, watching what a big player like Ontario does, and give them some time to put it in place and assess it, and determine whether or not that's what you want to do. And to be frank, in Ontario, there are so many drugs that have had exceptions because some people say because the cap is at 25%, it went a little too far. And if you have a lot of exceptions made to the cap, that requires a certain amount of bureaucracy to do the assessment of the appeals, gather the information, hold the meetings, all of that kind of stuff. The savings that you think you're going to get, you eat up pretty fast in having to construct a whole bunch of bureaucracy to enforce a 25% cap. So we decided 35% seemed like a reasonable level to arrive at. We certainly will see significant savings. The consumers will see significant savings. Taxpayers will see significant savings. Hopefully it will avoid the problem of exemptions and a lot of difficulties. And at the end of the day, we will be able to, know that we've gotten a good and fair deal on drug prices for Nova Scotians. And when I look at other provinces, the 35% cap is what they've arrived at as well. So we're in very, very good, we're in very good company. Now, there are a number of other things that we're doing with our Made in Nova Scotia plan that Ontario did not do, or that Ontario did and we decided not to do. Ontario abolished rebates, and we had, there's a fair amount of discussion about rebates in the media back in the fall when Ontario did their plan, and I think the average person had no idea such a thing existed. In fact, you'd have to be pretty much in the know in the industry to know that there was such a thing as rebates in the pharmacy business for the most part, right? And so this came as, I think, a bit of a surprise to many people that manufacturers pay pharmacies to stock their product. And it's a common industry practice, in a lot of retail type businesses. It occurs in the grocery stores, in the grocery industry, and it occurs in quite a few industries in retail. So pharmacy is no different. Ontario made it mandatory that pharmacies report for a period of a number of years. They report their rebates, and they started a process to eliminate their rebates. Rebates would be completely eliminated. Some people say, and I don't know, we'll have to wait and see, some people say that capping the prices of generic drugs will ultimately lead to an elimination of rebates, or at least a reduction in rebates. I don't know if that actually will be the case. But that's not our objective. Our objective isn't to, that's a business practice that goes on between the industry and the retailer, and that's kind of up to them to sort out. Our concern is not around their business practices and the transparency of their business practices. Our concern is fair drug prices for Nova Scotians. Our concern is that Nova Scotians shouldn't have to pay prices for generic drugs that are unreasonable. They should get a fair price for a generic drug. If it's a generic drug, we expect to have a fair price. And certainly that's the thrust of our legislation and the intention and focus and the mechanisms we've built into that legislation. There are probably a number of other things I could say about this legislation. It's very complex, as most things are in the healthcare system. We need to be aware that as we move this policy forward, that we want to make sure that Nova Scotians have access to their community pharmacies. We recognize how valuable community pharmacies are to people, especially in rural communities, but in all communities, including urban and small town Nova Scotia. People will know that, members will know, Madam Chair, that we're also doing work to expand the scope of practice for pharmacists. And there are some members who would like to tie that work in with fair drug prices. And I've been reluctant to do this. You know, this is an issue, fair drug prices for Nova Scotians on generic drugs is an important enough issue, a reasonable enough focus of public policy to stand on its own. Now, we also want pharmacists to be more fully participants in collaborative healthcare practice. Our healthcare system is changing into a more collaborative model. It's changing into a model where we are using the knowledge, the training, the expertise of the various healthcare providers. Before I was elected to this chamber, I was a member of the Faculty of Health Professions at Dalhousie. Pharmacy is a school in the Faculty of Health Professions. And pharmacists are really amazing people as a profession. Professionally, their knowledge base is really quite remarkable, very, very interesting. They know so much about not just a drug. What in particular I came to value a lot about pharmacists was their knowledge about the interaction of different drugs. And in today's complex medical world, you want the people who have that knowledge to be very heavily engaged in healthcare decisions. And, you know, I have a great deal of respect for what physicians know and can do, but physicians do not have, and they'll tell you themselves, they don't have the same degree of expertise and training about the interaction of pharmaceutical drugs. And that's why we need pharmacists to be more directly involved in the collaborative care of our population, especially where we're now managing complex chronic diseases. And so we, in fact, have been working with the College of Pharmacists to expand their scope of practice, to recognize their expertise and their knowledge, to give them a greater role in the provision of health care. And, you know, this is a process that we have initiated and we will see through to completion. The idea that I or any member of the government will negotiate tariff agreements in public or around the fair drug pricing plan is not really going to happen. This piece of legislation that I've been talking about will focus strictly on getting fair and better prices for pharmacists or for Nova Scotians. And the way we expand pharmacists' practice, scope of practice, and bring them into the healthcare system is another conversation, and it's one that's underway, and it's one that we will negotiate fully and fairly as we do with all of our healthcare providers. I want, Madam Chair, to take a moment to table for the members. I had made reference to a couple of examples I had on what people will save under the Fair Drug Plan. And these examples show a senior who has a single prescription in the Seniors Pharmacare program for a particular kind of medication for rheumatoid arthritis. And with the cap set at 35%, the senior would see a savings, an annual savings over the year of $382. And, pardon me, that's the copay, that's right. And I have the an example from the Family Pharmacare program of an individual on a drug for bipolar disorder who would realize a savings when the cap is in place of $70.13. So this will result in money in the pockets of Nova Scotians as consumers, as patients, and as taxpayers. And that's a good thing, Madam Chair, we think.
Member for Hants West.
Thank you, Minister. That was a very detailed answer to what I thought was a fairly simple couple of short questions. And anyway, I won't get many questions into my hour, I can tell that already. From your very detailed answer, which I appreciated, I do want to say, but I'm not going to go faster, no. I guess I would say at the same time, thank you. You certainly have the ability to know your department well enough that you're able to be on your feet and speak extensively on topics that are important, like the drug plan. And I do believe it is important. And as I said early on, that the pharmacies, and I've not spoke to my local pharmacists, but I do have a call from them, and there is some anxiety around all of this, and I'm not sure what those details are yet. But there is talk that they're going to need to change their business model, et cetera. I don't know what that means exactly either. I'm aware of the manufacturer's rebate, as you called it, and how that's gone on for years and worked. And I'm also, as most members in this House probably are and have been for a very long time, the cost and the struggles that people have trying to buy those drugs and even paying the, what is, I guess, deemed to be the small amount of copay, not so small for some people. Based on what percentage that is. So I guess there was a lot in the answer that you gave me. $6 million savings, I guess, is what I was getting at, which is fine. Then you used the word we an awful lot. And I'm going to assume in this case that we means government in those that you support by way of purchasing drugs. And, excuse me. And that's the we that you're referring to. But what about those that are out there? They're still going to pay that copay. So I go to the drugstore. You may buy the drug cheaper overall as a province, as a government, but my copay is not going to go down. I'm still going to be expected as a senior, and they're a better example, as the senior who has to pay $382 first a year before they've rid of the copay. Their copay is still going to be $10 or $20 or whatever it might be for their percentage of that drug. So I'm not really sure. I'm not getting where I see the savings, I guess, in purchasing and to government. That's great. But where does that get passed on to the senior and or the taxpayer? I don't see that yet. They're still going to have to put that money up front. I guess I was thinking that perhaps their percentage or their copay, there was an opportunity here to reduce that by way, then you have a savings directly in or out of the pocket, I guess, depending on how you look at it, to the purchaser at the counter. That's where I was going with this. That does not appear to be the case. There's no direct savings when I go to the counter to buy my drugs as a senior. There's no reduction in the amount of copay that I'm paying, or whomever's on the pharmacare plan. They're still paying based on their income and how it's set. And I want to, before you go back to an answer, I want to move on to an example of that. I have a man and a woman who, the lady is 62 years old. She's on the provincial pharmacare plan and was just renewed and given a price based on the family income. Her husband is 68, I'll say. He's a senior. He's paying the $382 already. So what she can't understand, and I guess I have some trouble with it myself, is even though she's the only one on the pharmacare plan, and he's already paying and been assessed because he's a senior and paying the $382 and he gets the GIS, et cetera, that's already determined. The rates are set. She's got to pay $700 some because the income is based on her and her husband's both. Hers is about $4,000 a year. There's an issue there. You talk about fairness and drugs. She can't even afford to go to the drugstore and get drugs that she needs. And she's a lady who's had a stroke in the past, who needs her Lipitor, who needs a number of drugs, as you can appreciate, that are expensive. So she's got to go to the pharmacy. We're calling the pharmacy trying to work a deal of a payment plan. Pharmacy saying, no, we can't do that. We don't do that for people. And her drugs are like $500. So here's a lady who's stuck. You talk about, fair drug plan. Here's a lady who's stuck with a bill somewhere between, depending on how many prescriptions she gets, about $500 and can't get her drugs, so she's going to go without because there's no other means of getting them. She goes to community service. No, she's not a client because their income's around $28,000 a year, even though they've lived for the last 3 months without a furnace. You just have to really know this entire story to appreciate where I'm going. But you can sort of get the flavor of what I'm saying and where these people are at. They're not alone. They're one couple of example of many around the province. But I don't see a direct link to a savings at the gate, if you will, in purchasing of your drugs. So I guess I'm either not understanding it clearly, and I don't know how far we can go with a bill on the floor of the House as far as the debate goes. I know it's a line item in the budget, and the chair has been very lenient as far as the amount of discussion on this piece of legislation. She did speak on, okay. But at any rate, I don't see the direct savings, and I think that people are going to struggle, Minister, to see that direct savings if they're still going to the drugstore. And, you know, and having to do the same old process, and there's no saving that they're seeing. So again, if you want to spend a few minutes on that, just to maybe simplify for me what I'm missing here, because I don't think I'm alone.
The Honourable Minister of Health and Wellness.
Thank you very much. It's a great question, and I would think that, you know, lots of people would have this question, so it gives me an opportunity to explain a bit. The copay is a percentage of the cost of the drug. It's not a flat rate, you know, so every copay, so maybe, you know, I know that we have Blue Cross as members of the legislature, we pay into it, and if we have a prescription, we pay a flat rate, you know, $9 and something for a prescription. The pharmacare programs that we have don't work like that in the province, okay? So they don't have a flat rate for a prescription, they have a percentage. So they pay 30%, a senior pays 30% of the cost of their prescription until they have spent $380 some and they reach the maximum in copay, right? So if the generic drug price has come down, then their copay, the percent that they pay, will also come down. And so that's why they will pay less. And this works in the same way around the family pharmacare program. But it is a valid question, and it is the explanation for how we look at savings to people at the counter.
The Honourable Member for Hants West.
Thank you, Madam Chair, and thank you, Minister. I do understand that part clearly, and I guess in the end of the day, and we'll use that same senior as an example. That's great that we're getting a discount in the price of drugs if you're capping it at whatever the fee is, but the $382 is still the $382, I guess, is what that senior will see. It's being pitched $6 million. I don't think that the public is really clear on it, especially the seniors who are on the fixed incomes or the other clients that are on the pharmacare plan, regardless of what their maximum, whether it's $382 or $1,000. I understand fully how that works. I understand where the discount is. Obviously, it's on the price that we are purchasing the drugs for. But in the end of the day, it's just maybe 1 week less in the year or 1 month less in the year. They reach it sooner is really, I guess, if you really want to look at it, they may reach their 382. No, they would reach their 382 later on, not sooner. Sorry, I had my math backwards there for a second. I see the deputy had a quick thought there. You're right. So it's stretched out. It takes a little longer to get it paid for, but they're still paying the 382. So I'm not sure that they're going to say, it all sounds good. The $6 million that you're talking about saving, I would be probably more supportive of the idea that the $6 million would go back into something which I'm not hearing much about. Where are they going to see the savings? Where's the senior going to see the savings, or where's the pharmacare? Where's anybody? Where's any Nova Scotia going to see the $6 million savings in a $8 billion plus annual budget? $6 million is $6 million, in my opinion. $10 is $10, in my opinion. But every bit of savings is a savings. But I don't think it's. You have to clearly understand that Nova Scotians want to see a savings. They want to see what they're getting for their money. if you listen to them talk, and I know you do, that everyone complains about the same. I get nothing for my money. The tax dollars I pay, I get nothing for. Although if you travel around the world and have a look at how some other maybe third world countries live, you might understand that you're not doing too bad in some cases. We do and are fortunate enough to have a pharmacare plan. I would jump up and down and support that wholeheartedly. I have had the opportunity to travel to some places, and as far as I'm concerned, we live in the best place in the world, right here in this very province, let alone this country. You know, we're always going to have taxes. I think that's probably fair to say. We're always going to have rising costs for things, and I think that's fair to say. But people want to, it's great when politicians stand up and say, we're doing this, and we're doing this, and we're doing this. People want to be able to really read something into it, and they want to see something for their money that they're getting. And I think, I'm not sure that they're really seeing it face on here when they're not going, maybe I guess they'll see it, as you've said, when they go to the drugstore and they pay that percentage. You know, 10% of $35 is better than 10% of $65 or whatever the cut, just as a very rough example might be. So I'm not saying that that's not a benefit. I believe that it is, and you know, I look forward to that cap becoming in place if that's the case. But I'm also interested, and I know I'll be coming back again after, but you know, and hearing what the pharmacists have to say. I need to learn more about what that is, and I'm sure that you're going to hear a lot about that in the coming days and weeks as you negotiate and as you debate this bill and as it makes its way across the hall. But I'll leave that for now. I want to get on to a little bit about the doctors. And what's my time, Madam Chair?
You
34?
have approximately 14 minutes.
Oh, 14 minutes still, thank you. The doctor's salaries, it's a never-ending issue of can't find enough doctors in the province. We're not doing anything about recruitment. I know in my area, in Hants County, Windsor specifically, most of the doctors are located there, not all of them, but most of them. They're not getting younger, and they'll tell you that. They're looking, you know, they've been around there for as long as I've been around, so, you know, a lot of years. They're thinking about retirement, but at the same time, they're thinking, how am I going to do that? There's nobody to come in and take over. I think some of them that I've spoke to, like the clinic idea, we're fortunate to have a clinic 3 nights a week, but it's for 2 hours. It's busy, but they're quick. People that are there are the people that should be there. They're the ENT stuff, the ears and the eyes, and the, you know, they need a script for this. They need, you know, this is a very, very, very good thing. The expanding of that clinic is something that would be very well supported. You talk about emergency rooms, and I've had an email, and I've had calls, and we've had rumors for years, oh, Hants Community Hospital is going to close. Fortunately, it's still open. I can't remember a time when we've gone without a doctor for a shift in the ER, day or night, but that is because of the dedicated individuals, the 3 or 4 of them, that are so committed to staying there and making sure that that doesn't happen, even if it's working day after day after day. Some people would call them crazy. They might call themselves crazy, but they're committed to the people of the area, and they're committed to keeping that facility going because they see what happens around the province when, you know, Glace Bay and Spring Hill and different places and the South Shore down there and a whole variety of places for that matter have issues with doctors, and it doesn't get better. Once it happens the first time, it just seems to keep going because, oh, we've survived it the first time. We go a second time, and this has gone on for years, as you well know, and certainly from my past, I well know what that means to a community. I also know what our little hospital out there in Windsor means to our community, and I realize that it's in the Capital Health District. We have an interaction with the Western, with the Valley Regional there, and personally I think we have the best of both worlds. We have the resources all around us. We're close to town here, and we're close to the Valley. We have good working relationships, I think, within all of that corridor. There are some worries about cuts to this facility, and you never hear about the facility, you hear about Capital District. That's, you know, the number of staff, the number of dollars being cut out of the Capital District. Again, there's this download from the provincial government that says, we're going to go to the district and say, you got to do this and you got to do that. So they're the one who's actually responsible for reorganizing, reevaluating, cutting, use whatever word you want. Doesn't matter. At the end of the day, it means the same thing. And potentially that's a decrease in the service. Now again, our hospital is very well served. It's busy, whether it's in the morning and the blood work lineup and x-rays or whether it's emerge, it's steady. I'm sure that it's been assessed. I'm sure that there have been discussions about Emerge being open through the wee hours. I mean, I think that's probably taken place across the province, and how are we going to manage that? And we all know where EHS has come in and how it's come in, and the part and the role that they've played. I think that's a wonderful thing, by the way, and I know I have a bias coming from there, but I've seen it work. And I can stand here and say that it works very, very well. We have one of the best ambulance systems anywhere in North America, in my opinion, if not the best. Been part of that and been part of watching it grow and helping it, and support it wholeheartedly. I think that there is a huge role for paramedics in this province to play by way of healthcare, not only emergency and in the streets. I believe that there is a role for them to play in the hospital. It's not new. It was done here at the VG solely for years. Medics worked. It's now done at the Q, and we've seen that expand to different places around the province. And for years, this is not new, for years paramedics have been in hospitals when doctors have not been able to be there, not only to treat but to transport as needed to a higher level of care facility. That is open. That's a good thing. That's something that we could not count on, 10, 15 years ago. That would not have even been heard of, and we've come an awful long way. It's a resource that we have to continue to use. And we also have, of course, you've heard me stand in this house and talk about nurse practitioners. There's a huge role. We're fortunate. We have Dawn Lowe. I know the people in this house are certainly familiar with her and the work that she's doing for Dr. Iona Weil. I'd take another half a dozen Dawn Lows if you can afford them. We'll take them tomorrow. We have room for them, whether they be in the clinics, whether they be in Emerge, or wherever they might be. The roles have to be thought of and expanded. The paramedic roles, there's lots of them out there. There's room. And we can all argue about cost, but a doctor or a nurse practitioner or a doctor and a paramedic, not that one is any less valuable than the other, but we can provide service at high levels. I mean, if you take a paramedic today, they can do more than a nurse can do in the Emerge for you. In all honesty, in the street, they're giving drugs, clot-busting drugs. They've been doing that for years. Defibrillations, you know all of this. I don't need to tell you. They're very, very well qualified. And if you have any hope, you have it there at that level, on the street and in your home. You have it right there today at your hands. That costs us a lot of money. I'm aware of that. Appreciate it very much. But what the people are getting in return is of great value. So I do hope that there are plans to expand that even more, and we've heard of all kinds of things, whether it's about drawn bloods or whatever it is. I do believe there's an expanded scope there that's not been tapped yet. And again, I don't say that coming from my background as a bias, but I believe it's an honest bias and a true bias that's relevant as we move forward in the healthcare system. I do want to say as well that we need to find a plan to do doctor recruitment. And I know about, we've talked about opening spaces at Dell as an example. That takes a lot of years though, and I'm not saying it's not a good thing, because you have to start somewhere, and somewhere down the road, hopefully that will be beneficial. I wonder, Minister, has the thought been given to, I don't want to say, I'm going to use the word incentives. A lot of doctors getting out of school don't want to go to, rural Nova Scotia, where there's not a whole lot happening. They don't have all the new and up-to-date gear by way of the greatest technologies, although the world is becoming smaller and smaller by the day, in my opinion, with regards to the advancement of technology. Is there some consideration being given to incentives for doctors to get out there, whether that be paying tuition fees at schools for part of it or all of it, or buying them houses, or I don't know what they do on all of the, but you know yourself, Minister, you hear all these stories about how we bring doctors into certain countries and provinces, and I'm not saying it's the right thing or the wrong thing to do. My question is more out of curiosity. What are we doing by way of incentives, or are we doing anything? Maybe we can't afford incentives, I don't know. But if you talk to a lot of people, especially the seniors, we're not there yet, but before you know it, in a blink, we will be seniors. And those are the people, you talk to them on the street and in their homes, they're worrying about where they're going. They're worrying about the long-term care of their health. It's great that we have a new Windsor Elms, but it's the same number of beds as we left off with in the old Windsor Elms. Wonderful place, but it's not serving any more people. It's just serving them better than it ever did before, which was great at that point. So there has to be, I'm curious, is there a plan? If there is, what kind of dollars are around it? Maybe there are none. I don't know. I'm sure that you'll let me know. And what else are we looking at in the same vein? Along with that, maybe you can, I'm sure you'll talk in detail about all of it, but the EHS piece of it, the nurse practitioner piece of it, and the incentives for doctors to come to Nova Scotia, specifically rural Nova Scotia, because I don't believe that the emerge is actually, or not the emerge, that's not fair, that the HRM facilities, the core facilities, are struggling as much, and I may be wrong on that, and you can enlighten me as well if I am, in numbers of physicians, family physicians that are out there. And so I'd be interested to hear a little bit on that if you want to just touch. I know it covered a lot, but it's basically on the focus of the expansion of the system with those that we already have in place and incentives to make it maybe a better place to be here in Nova Scotia by way of care. Thank you.
The Honourable Minister of Health and Wellness.
Thank you very much, Madam Chair. With respect to physician recruitment, I mentioned earlier, I think today in question period, to questions from members about the situation in Cape Breton. The department has, a little while ago, about a month ago or so, we put out a request for proposals to develop a physician resource plan for the province. It's our, this will provide us with a 10-year plan for both specialists and GPs. And it's long overdue to have such a plan. What we've done until now, so actually, several of the DHAs have their own plans, but we need to have a very good comprehensive provincial plan for the province that will allow us then to redirect resources into more effective ways of recruitment and retention. One of the things that I've recognized in that we have more incentive programs in the department than you can shake a stick at to get physicians into rural and hard to service communities. And so I have a question about, well, why haven't they worked? Why haven't they worked in Yarmouth? Why doesn't this attract physicians to wherever? Why is it that we had an incentive program that gave incentives to physicians to locate in Timberley and Chester and Hubbards and Enfield, for example? That existed. That was the case. And you kind of go, remote areas, Enfield, Timberley, it's not all that remote. I could be wrong, but so there's a lot of there are a lot of things that existed in the past, and I'm sure if I was sitting in that chair in the past, there would be an explanation, perhaps a good explanation for why that occurred. But we are, we're looking at this with a new pair of eyes, and we're going forward, and we're looking to develop a very comprehensive physician resource plan for the next 10 years. And then we'll look at all of those incentive programs that we have, and we have a lot of them. And we will redirect and redesign them in ways to get us the results that we require for those plans. But it's never an easy, it's never easy. We see a lot of physician couples. So you have a need, for example, for gastrointestinal specialist in a community, and you go out and you recruit and you find somebody who really wants to come to Amherst or whatever, and they have a partner who has some kind of area of practice that we don't really do in that area, don't have maybe a huge demand for, and what have you. But, to get that one physician, a position gets created for a second physician. It's very complex. And it's hard to manage your limited resources in a very business-like fashion when you're dealing with human beings that have all kinds of other dimensions to their lives, So it's complicated. The medical school was, The seats at the med school were expanded twice. We haven't realized all of the graduates from those expansions yet. But when I look at the recruitment of physicians in the last little while into the various DHAs, and I talked about this the other day, we continue to see the Capital District Health Authority get a very large number of those folks. And the more rural DHAs have a harder and harder time recruiting. And you can see it. It's very clear when you look at the numbers. Now, one of the things that's going on is Dalhousie is developing residency programs with our support into rural DHAs. For example, there are residents that are going to be in the Annapolis Valley. And this will lead to, we believe, residents going into those DHAs and doing their residency there and developing professional relationships with other physicians and other healthcare providers, and realizing what a great lifestyle the Valley offers, for example. And at the end of the day, we think that will result in people wanting to stay and practice in those communities. But the biggest problem I think we face in some ways is that healthcare system is like the rest of the world. We have a very large baby boom in the physician population. We have a lot of physicians in their early and mid 50s in this province and getting on, and people who are planning for retirement. They're slowing down. It's not as easy to work the long, arduous hours as you get a bit older, and so these are all pressures that are part, but these are things we will capture in our physician resource plan. We'll have a better appreciation of the numbers of people who are planning retirement and when they're planning retirement. We will talk very much with the physician population. We may get a better understanding of people who would work part-time, semi-retire, but stay in the system. And a lot of the labor market research about the future of work and skill shortages in other fields are telling us that there is a growing appetite for people to bridge into retirement, not necessarily just walk away from their profession at some magic age, but there are people who kind of like to wind down and keep their hand in the workforce, so to speak. And so we need to get a better understanding of that, and I think that will help us considerably. Thank you, Madam Chair.
Thank you. And at this point, I think I would like to suggest, if it's agreeable with the minister, that we take a 5-minute recess to stretch our legs and perhaps a washroom break. So we'll stand for 5 minutes, please. Order, please. The time allotted for the Progressive Conservative Party has expired, so I now would recognize the honourable member for Yarmouth.
Thank you, Madam Chair. I'd first like to thank the Minister for making herself accessible to me and constituents of mine who have had issues and concerns about certain things in our healthcare system. The Minister has been very accommodating to those individuals, and like I said, has made herself accessible to chat with folks from my area and myself on a number of different issues. So I just wanted to thank her for that and let her know that I appreciate the approach that she's brought to the office. Now, Madam Chair, as the Minister knows, because we've talked about this in the House before, there's a lot of folks in my constituency of Yarmouth, and I believe across the province, that are faced with no access to family physicians right now. I believe during the last session in November, I tabled a petition signed by over 2,200 people, I believe, that were without a doctor in the Yarmouth area. Now, this includes seniors, children, people that are sick and require medical attention on a consistent basis. There's a lot of concern in our area about the shortage of family physicians and the access that people do have to our healthcare system that we all value so much. This shortage of family physicians has added to increased pressures on our ER system. The emergency room in Yarmouth is full all the time, with a lot of people that are in there for emergencies, but also people that are in there to have their prescriptions filled and to have service provided that should be done by a family physician. I've heard stories from seniors that are waiting 14 to 17 hours just to have their prescriptions refilled in the emergency room. Folks that because of their condition and their age and their health, sometimes can't be sitting in a room for that long waiting for emergency services. And I understand the way the triage system works, that needs to happen. But it all comes back to the pressures that are put on the ER because of the lack of family physicians. And I'm wondering, from the provincial standpoint, if the Minister can provide some insights into what the province is doing to address this doctor shortage issue, which I know we're all aware is a reality in our province. And specifically, I've heard that our provincial incentive programs haven't been reviewed within the last decade. And I'm wondering if there's plans to review those incentive programs and see if, as a province, we're competing to recruit and retain doctors here. I know that our local people that do doctor recruitment in Yarmouth do a fantastic job and do the best they can do with the tools that they have. I'm very proud of Shirley Watson-Poole and her colleagues and their ability to recruit doctors. We have an issue with foreign trained doctors or foreign doctors. They come in, they're excellent doctors, they're great citizens in our community, but statistically, a lot of those doctors that come in will fulfill their 4-year commitment through the CAP program, I believe, and unfortunately many of them will leave for reasons outside of a lot of people's control, whether it's places of worship in Yarmouth, access to transportation so they can go to bigger cities or other countries to see their family and all those sorts of things. We don't blame those doctors for wanting to leave and be elsewhere, but I'm wondering what else can be done to train, recruit, and retain our own doctors here in Nova Scotia, especially those folks from rural communities that would be more likely to go back into a rural area like Yarmouth or Digby or wherever to practice. So my first question to the Minister is, what's happening? Are we going to look at reviewing our provincial incentive programs to make sure we're competing as a province to recruit the best and retain the best? And are there plans in place where we can bolster the training of our own population here in Nova Scotia so we'll have a larger group of people that we can rely on to service our citizens in rural and high-need areas? Thank you.
The Honourable Minister of Health and Wellness.
Thank you very much, Madam Chair, and I want to thank the member for his questions, and I know how important this is to people in his community. I think, as Minister of Health, I received letters from all over the province, And it's clear from Yarmouth, I get probably the greatest bulk of the letters that I receive about not having a family doctor, not being able to find a family doctor. And so I often judge what's going on the ground by the correspondence I get from Nova Scotians, and I certainly understand that this is a problem in his community. In terms, let me start and just tell members about the entire province. It's slightly less than 6% of the people who live in our province that don't have a family doctor. Now, that's still way too high. We have this, I think we have this terrible term, actually. I didn't invent it, thank heaven, somebody did. There's this term called orphan patient in the healthcare system. Somebody's an orphan patient when they end up in a hospital, and that means they don't have a family physician, they don't have a treating physician, and they're known as orphan patients. If I could perform one miracle, it would be to eliminate the fact that people have no family doctors when they end up in a hospital. There'll be no more orphan patients. I think there probably will always be people who perhaps even by choice don't have a family doctor. But the fact that people want a family doctor and can't get one is unacceptable in our province. It's just simply unacceptable. And so we're working really hard to deal with that. And I think in terms of the finance people in the Department of Health, we call them unattached patients. And we have allocated close to $500,000 in this budget to ensure that although they don't have a family doctor, that they get the treatment that they need. Now, with respect to the honorable members, DHA, Southwest, when I look at the number of physicians that were recruited in the 2010, your DHA has done better than any of the DHAs. And I think this reflects the priority that's been placed on getting physicians in there. It reflects the hard work of the DHA, and it also reflects the commitment of the government and the department. And of the physicians who have been recruited into that DHA, there are 11 in total, new physicians, 5 specialists and 6 family practitioners, and of those 11, 2 were foreign-trained doctors, the CAP doctors. I think Pictou County is the only other district that comes close, and they had 7 in total. So you have 4 more than Pictou County, and of course that excludes the capital district that had 52 in total, and you can see where the problem lies. 14 family practitioners in Halifax and 38 specialists. So it is a challenge. What can we do? What tools do we have? As I said, we have a lot of incentive programs that we use to make it more attractive to practice in some of these hard to recruit to or underserviced areas. We have, in our budget, we have $1,364,000 allocated for retention incentives in rural communities. And we also provide what are called alternate payment plans, so that The rule of thumb is often that you need, I think it's 2,000 patients on a fee-for-service basis to have a average salary for a physician. But if you're in a community that doesn't have the population to support, let's say, 4 docs, 2,000 patients each, we have these other plans where we will pay people, they don't do fee-for-service as their pay, we pay them a salary to provide services. So we have a variety of incentives to get people into underserviced and small communities. Not that Yarmouth is small, you have a substantial population in that area, maybe a little spread out, but some very good facilities. And so it is, as I said, it is a challenge, and it's a bit of a mystery on one level. When we have so many incentive programs, I ask people in the department, why is it that these programs work some places and they don't work others? What's the explanation for that? And we are currently doing a 10-year physician resource plan where we will look at what the needs of the population are, what the current physician complement is, and what retirements are going to look like in the future and what have you. And we will develop a plan, and it is after we have that developed that we will look at our incentives and how we need to refocus them or restructure them to get the results that we want to implement our physician resource plan. We have a physician recruiter in the department, and you know, she is active all the time, going to conferences and doing all kinds of work where physicians are, meeting with physicians around the country to see if we can attract physicians from other provinces and other jurisdictions. But it's not enough and to go outside and recruit from outside. I think the member has addressed, has raised a really important issue, and that's about training people from our own province and then retaining them here. Or having, one of the things that I ask about and we're trying to understand better is how many Nova Scotians aren't training in Nova Scotia but are training elsewhere. Students who are in McGill, U of T, other medical schools, American universities, Australian universities. You know, we hear about, sort of anecdotally, we might hear, or we may have a Nova Scotian student nearing the end of the 4th year of their program looking for a residency back in Nova Scotia. We need to have, I think, a better way to identify and track Nova Scotians who don't necessarily study here and make sure we have every opportunity we can to get them back home to practice. And as I said earlier, and I think I was able to give the honourable member this information last year in one of our question periods, Dal Medical School are starting to place medical school students as part of their practicum in the Yarmouth area. And DHAs are looking at setting up residency programs outside of Metro, around the province in other DHAs. And I mean, it's not going to happen in every DHA because there is quite a substantial cost involved, but we will look at residency programs in rural DHAs that will allow that DHA to connect with local medical students and have a greater potential then to recruit them and retain them at the end of their residency. So there are a variety of things that we have. There are some new things we're trying. and the work of the physician resource plan that we're doing are all parts of this puzzle. Madam Chair, I think one of the greatest tools that we will have for recruiting and retaining family doctors in rural communities is the Better Care Sooner plan with the collaborative care centers. This is going to promote teams of doctors and nurse practitioners, advanced practice nurses, and other care providers in settings where the pressures will be taken off the family doctor to work collaborative models, and the pressures will be taken off the family doctors from having to work all night in the emergency room and come in the next day and provide care throughout the day. Already I'm hearing from doctors who are working in collaborative models who were diametrically opposed to any such form of practice, could not imagine moving in that direction, were just absolutely implacably unmoved by arguments about why this would be a good way to practice medicine, who can't believe they felt that way now that they are working in collaborative teams. They love it. Their quality of life has been improved. The work that they do in the medical settings has improved, and they thoroughly enjoy working collaboratively and find it just very invigorating, and it's kind of renewed their passion for practicing family medicine. So it's great. It's really quite inspiring to go out and meet with many of these doctors and hear from them and have a little laugh, because many of these people I'm meeting for the first time, and they're explaining to me how opposed they were to this model some time ago, and how it really has changed their view of practice, and they're really excited about it. So it's kind of infectious. I have to say I've enjoyed that thoroughly. So our commitment as a government is to take pressure off the emergency rooms. I was in the emergency room in Yarmouth, I think, in the first month that I became minister, and was on a hot summer day when we went down to open the, it was beautiful. It was a beautiful day. It was a hot summer day. We went down to open the cancer center, which is a phenomenal facility with a beautiful view, one of the most beautiful views from any healthcare facility that I've been in. And but before that event, the staff at the regional hospital took me on a very comprehensive review of the facility, including the ER, and it was packed. It was very, very busy, both in terms of people who EHS have brought in on stretchers, with very serious cardiac situations, as well as the prescription people sitting in the waiting room waiting for prescriptions. So I understand entirely the problems. The problems have eased a bit. As I said, in Yarmouth, you still have too many patients without a family physician, but there are less patients there without a family physician today than there was last year. And you have some phenomenal experienced family practitioners in that community. Dr. Sheila Leahy is very well known throughout the province, and you're very, very lucky to have someone of her caliber in that community, and she has mentored many, many, many physicians in your area and beyond your area and outside of the province as well. So you asked the question, what can we do about foreign trained doctors? They come under the CAP program and they stay for the term of their contract, and then we often lose them. It is a challenge and a conundrum. I was struck when I was in Cape Breton at the ability that they have in that district to retain. It's like a mini United Nations. When you go to their medical staff association, there are physicians there, both specialists and family practitioners from probably every country in the world. It's just amazing. And I want to say, I mean, I've been in a lot of the other DHAs and I haven't met with the medical associations as such. So I don't have, you know, a group of 70 or 80 doctors that I'm meeting with. But the evening I was in Cape Breton, the kind of collegiality and camaraderie between the physicians was very obvious. They like each other, they get along, they work together, and they kind of socialize together, and they have quite a good relationship. It was very, very apparent. And I spoke with Dr. Nakvi, who's their medical director, and he's worked very hard at building, you know, a very collegial, accepting, open team environment where people feel included. And, you know, I think that his leadership and his wisdom, he's very wise about what makes people feel included in a community. I don't know if it would be possible to have an opportunity to have him in your district, you know, to talk about just his very long experience. When I was first a member elected to this legislature 13 years ago, Cape Breton was experiencing serious shortages. And I remember being in Cape Breton. I was my party's health critic, and Dr. Nakvi took me around the island to the various facilities and talked to me about what his recruitment plans were and the difficulties. And he was very inspiring. He was very passionate about Cape Breton and about what they had to offer people. And when you go there now, you see the end results of his work. And he's very, you know, he's very low key, but he's quite persuasive. And I'll tell you a little story they actually told me that night, because I made a note of you know, what an amazing job he had done bringing people into that district health authority. And one of their newest recruits told me that Dr. Nakvi had met him at a conference. I think he was an American, actually. And he had met him at a conference, and he started telling him about Cape Breton and telling him he should come to work in Cape Breton. And he got the doctor all of his contact information. And after the conference was over, Dr. Nakvi went back to Cape Breton, and he called this gentleman, this doctor, American doctor. He called him pretty much every week. And his wife would answer the phone and hand the phone over to her husband. And finally, one evening, she answered the phone, and she handed it over to her husband, and she said, "For God's sakes, will you tell that guy we're moving to Cape Breton so he'll stop calling me?" And he was very persistent and very persuasive, and it shows. I mean, it really does show. The Cape Breton Medical Association are, you know, again, they're populated with people from all over the world, and a lot of the recruitment there is directly attributable to the efforts of one individual, and sometimes that's what it takes. It's the dogged persistence and the vision and the leadership, commitment, passion of one individual that can can change things. So, and he's a very generous man. I'm sure he'd be more than happy to talk about what has worked and what, you know, what doesn't work so well. So with those remarks, Madam Chair, I'll take my seat.
Thank you. The honourable member for Yarmouth.
Thank you, Madam Chair. Minister, thank you for answering some of those questions. I do have some questions that came up as a result of those. I know you mentioned that there's a 6% number of Nova Scotians that are without family physicians. It does seem that for some reason in my area that percentage is higher. We spent some time collecting data, and as I mentioned, I tabled a petition in the House which listed at least 2,200 people without family physicians. And I think that number is much higher than that, but I mean, that would be about 14%, that number alone, 14% of our population in Yarmouth County, which would be the constituencies, or my constituency and the constituency of the member of Argyle. And you mentioned that there's a $500,000 to help patients get treatment that are orphan patients. I would be interested to know how that money works. If there are any systems in place or processes in place where individuals need immediate assistance, need continual care and service from a family physician, if there's some sort of process that these people can access so they can get the service that they need, because I'll tell you that, you know, there's seems to be a few major issues in Yarmouth right now, and the lack of family physicians is the one I probably get the most calls about, other than the ferry. And you know, I believe that there does need to be some immediate steps taken to address this issue. I think that you know, I think it's very important. I would urge this government to move to review its incentive programs immediately, so we can see if we're competitive, see if we can do better to compete and to recruit and retain doctors, and compete for the most talented physicians out there. But I also know that you need to put forward a long-term vision to ensure that this is a you know, a situation that doesn't go on for a long time. I'd also be curious to wonder about the I believe you said 1.5 billion. I'm not sure in terms of the retainment incentives. I'm wondering if those dollars are all used. I'm curious about the I think it was 1.5 billion. I could be mistaken on the number you gave for retention incentives, and I'm just wondering is that money used every year? Or is that actually getting out to doctors and physicians to actually recruit them there? Is the money being used? Because it's, you know, you can always have money sitting somewhere, but if the folks aren't actually getting it, then it's not going to do what it's intended to do. I'm encouraged that you mentioned, you know, collaborative practice. I think this is an area where the province should definitely be moving into. I know we have in certain districts. I remember reading an article in Reader's Digest about some groups doing collaborative practice in Ontario, and a physician went from not being able to service 3,000 clients under the regular model to moving to a collaborative model, and she was able to successfully service with her teammates over 19,000 clients. So I mean, there's some, I think, hope in looking at some of the other models that are out there, and I think those are things that we need to move on immediately. In terms of ERs, it seems the long-term solution is to recruit more family physicians so there's less strain and pressures on the ERs. But there does need to be something done immediately to help with that congestion. I mean, I have weekly calls and emails about people that are frustrated with the wait times, and I don't think that's any fault of the physicians that are there or the nurses that are there. It's because of the system we have in place and its deficiencies. And I'm not sure how you address that concern immediately without the family physicians to fill the spots. But I think that needs to be you know, an immediate goal of this government, is to look at that issue and try to address it in the best way it can. I'll also move to another. Actually, Minister, if I guess I'll pass it back to you to answer some of those questions, and if we can be brief, and I can get to some next round of questions that I have on a different topic as well. So with that, Madam Chair, I'll let you pass it back over to the Minister. Thank you.
The Honourable Minister of Health and Wellness.
Thank you very much, Madam Chair. The member asked about the money that that I mentioned earlier for unattached patients. That's for if unattached patients end up in a hospital. That's to cover the costs of physician services, to incent a physician to see an unattached patient that's not theirs. But I think that the bigger question is getting sufficient family physicians and other healthcare providers in collaborative practices, primary care, in the places we need them around the province. And that will do a great deal to cover all of the people in the province. We have in this budget $1.5 million for additional nurse practitioner support. And the thrust of Better Care Sooner is to get collaborative care centers up and running and get primary care working in a way that will take the pressure off ERs. Now, I know you have three, Madam Chair, the honourable member has 3 ERs inside the DHA in the community that he represents, Southwest. Digby, although that's in the honourable member from Digby, his riding, Digby, Shelburne, and the Yarmouth Regional Hospital. Regional hospitals, one of the things that Dr. Ross talked about in the Ross report was he recommended to the Department of Health that we look at the flow of patients in ERs, that ERs, there's a lot that you can do to improve people flowing through the ER, and we need to consider doing that in our regional hospitals, and that's certainly something that we will be doing and have started doing. But clearly, in a community where you have a physician shortage and the kind of shortage that you've indicated, then if people can't get to see a doctor to get a prescription filled and they have to go to the ER, that places a huge burden on the staff in the ER that need to be seeing emergencies. And that person who comes in wanting a prescription is going to sit for a heck of a long time if there are cardiac people in front of them and broken bones and what have you because of the triage system. So ultimately, and you know, let's be frank, this isn't a problem that's peculiar to Nova Scotia. The ER problems are problems right across the country. The lack of access to primary care is a problem right across the country. The fact that we have a model of medicine that we have developed, we have allowed to develop, we have supported in developing with the way we fund and what have you, is a model that has allowed family practice to happen Monday to Friday, 9 to 5, and then you went to outpatients. And the emergency room became the default for not having access to primary care in the evenings or on weekends. And that's what we're changing. We are changing, we're transforming the fundamental model of medicine, taking pressure off ERs and getting people into primary care clinics and practices where they can see a healthcare provider that's going to be able to meet their needs at their scope of practice. There are other things we're doing to assist family practitioners, you know, expanding the ability of pharmacists to prescribe, to renew prescriptions. These kinds of things are going to make a big difference in terms of people not having to go to an ER to get a prescription renewed. So I guess what I would say is that help is on the way for our system. It's not, these measures aren't things that you can do at the drop of a hat. they require a fair amount of detailed work and consultation and involvement of other the whole continuum of healthcare providers. People need to buy into the change that's happening in our healthcare system, and they are. They are, because I think everybody has recognized the question of the sustainability of the old system and the fact that people weren't getting the services that they needed and they wanted under the old system. So these things are certainly changing. I want to end, I guess, by again saying that we will be doing the physician resource plan. It is a plan that's going to look out 10 years. And at that time, it will, once we have that, then we'll have to look at achieving that plan and taking the various programs we have and refocusing them to get to achieve the implementation of the resource plan. So it's not that far away, actually. We expect that we will have our physician resource plan completed, I think, by the end of the summer. Yes. By the end of the summer. And so we'll be moving fairly quickly after we get that.
The honourable member for Yarmouth.
Thank you, Madam Chair, and I'd like to thank the Minister. That information is helpful. I'm glad the province is moving forward. I'm still interested in terms of the money the monies that are allocated for our incentive programs now, if they are being used to their full potential, if the research around those or the tracking of those incentive programs would indicate that they're effective. And again, I think perhaps they're not, because they haven't been reviewed in over a decade. And I think it's time that the province move to review those incentive programs to ensure that we're competing and that the programs we're offering are doing what they're intended to do. I also, think it's important to look immediately at what we can do to recruit and retain our own people, as I spoke about before, and perhaps that could be a number of financial incentives to get our young people into the system. One more thing I think we can look at is Canadians that are actually studying offshore in med school offshore. According to the Canadian Residential Matching Service, there were about 3,500 Canadians that are studying offshore. And in a survey done in 2010, there were about 105 Nova Scotians out of 1,082 who responded who were studying offshore. So I think another area we can look at is facilitating integration of those future doctors back into our system as quickly as they can get in, to ensure they have the credits and the licensing, whatever they need. I've heard from some people my age who are studying offshore, and they find it very difficult to get back into Canada and to practice here, despite the fact they're studying in England and Australia and the U.S., places that we wouldn't think would have an inferior medical training system in place. So that's another area where I do think that we need to look at as a province to ensure we are facilitating that engagement and that involvement from those people that are studying abroad. Another topic I did want to discuss is the model of care initiative that I know we put forward. Now, from what I understand, this is designed to alleviate the strain on RNs, I believe, and to allow RNs to play more of a supervisory role with a wider group of individuals. Now, I've had some concerns brought to my attention from healthcare professionals from my district, people that are actually involved in the healthcare system, and there are some concerns around this. Whether it's the fact that perhaps in certain cases LPNs don't have the qualification needed to care for specific health-related issues with patients, which perhaps might be putting the patient in jeopardy. And I'm not saying that LPNs aren't trained, but from what I've heard from some people in the field is that this practice might be putting some patients in danger. And I realize that the province has reviewed or evaluated the model of care initiative from a team perspective to see how the services are being distributed from a healthcare team perspective. I'm just wondering if we've evaluated it from a patient care perspective, and that we're ensuring that patients that are utilizing healthcare services have the attention that they need from the level of professional that they need to address them, so we aren't putting our patients in jeopardy. You know, I'm also wondering if this is going to lead to you know, less RNs being hired in the province, or less people that are trained to be RNs actually getting the pay that they should get by being an RN, and having them remain as LPNs. And you know, I think it's an important question to ask. Are we going to lose RNs in this province because there's not enough jobs for them here? Are they going to go to other provinces? Are people going to want to train to be RNs in this province? And you know, will this model of care initiative impact the number of RNs that are being hired in the province? And you know, I'm wondering if we're going to lose any, because I don't think that's something that I would like to see healthcare professionals at a level of an RN actually leaving the province to go somewhere else. So I mean, these are concerns that have been brought forward to my attention by like I said, healthcare professionals who are concerned about patient treatment, patient care, and who are concerned about, you know, their own jobs and whether they want to stay in Nova Scotia with the training level they have if they're not going to receive the designation and the pay that comes along with that specialty. So, questions again: have we evaluated this model from a patient care perspective, and are there concerns from the department standpoint of us not providing the level of care that's required for some patients, and if we're actually going to lose some of these trained people to other jurisdictions because of this model? Thank you.
The Honourable Minister of Health and Wellness.
Thank you very much, Madam Chair, and I'm very pleased that the member has asked this question, because it gives me an opportunity to talk a bit about the models of care and what that's all about, and what the evaluations are telling us this far. You know, I've talked earlier, Madam Chair, about making sure that we are using our health care workforce in the best possible way. So, to use a really simple example, we don't necessarily want to have our 4-year university-trained nurses making beds. Not a good use of their training. Not a good use of their skill. You want to have the right healthcare provider doing the right kind of care. If you're going to pay someone $50,000, $60,000, $70,000 a year, then you're not going to pay them to be providing you know, services in a care setting that I, who could never take a temperature, am not qualified to do. I can make a bed, though. So this is what the models of care is about. The models of care is about making sure that we have the staff performing the duties for which they have the training and the skills, and that we then pay them at that level for. So there are, I think, about 15 or 16 sites in different settings across the province where we have introduced the models of care. The models, and let me speak to the question about putting patients in jeopardy and danger and what have you. This health minister is definitely not going to go down a path where people's lives are put at risk in our care facilities because they're being treated by the wrong provider whose scope of practice does not permit them to do the things they're doing. In our system, nurses who work in our system have to be licensed. They have to meet the educational qualifications that are required, and they have to meet the professional qualifications to acquire a license, and they have to continue to maintain those qualifications and those standards to get a license. And it's no different for many other care providers in the facilities, in our acute care facilities. And as the member indicated, LPNs are very well trained and they're very well qualified, and they have the capacity to do the scope of practice that they are licensed for and that they are required to do in our facilities. And we would not have them work outside their scope of practice, and we would not have them do things that would put patient care in jeopardy or result in any danger. And I think it's very important that people understand that. The Models of Care initiative was developed with the full participation of the College of Registered Nurses and with the bodies that represent other groups of healthcare professionals. And it's overseen by the vice presidents of patient care in our acute care facilities. And I want to remind members of the House that our acute care facilities are accredited facilities, and they have to meet standards. They have to meet national standards that have been adopted and are accepted as the standards for operation for acute care facilities across the country. And we would never do anything in our facilities in terms of staffing that would put in jeopardy the accreditation of our acute care facilities. So let me assure the members of this House that we keep quality and we keep patient safety in the forefront of our considerations when we implement any changes in our facilities. But we are very much looking at staffing, and we are very much looking at enriching the job satisfaction of our healthcare professionals. And we want to make sure that, for example, our RNs are doing what RNs are trained to do, what they're skilled to do, and what we pay them to do. And the same for LPNs and et cetera, other care providers. Now, the early evaluations from the Models of Care are excellent. The RNs are very satisfied. The level of satisfaction for the nurses who are working under the new Models of Care is very, very high. I've spent some time looking at the evaluations, and they've been very interesting to read. And as is the case with LPNs and certified nursing assistants. And so we will continue to monitor how this is all being implemented and what the impact is. So I just, again, want to reassure the honourable member that, you know, our evaluations have been excellent from this perspective of the satisfaction of the staff. And in terms of patient safety, in terms of, dangerous practices, this is the issue of patient safety and quality is always utmost in our thoughts. And it's utmost in our thoughts for all of our healthcare providers. You know, we want to make sure that our most highly qualified, experienced surgeons practice quality medical care. We're working very hard with surgeons in this province to adopt the surgical checklist. You know, it's really interesting. And aviation safety, it's a well-established principle. When pilots get on a plane and they have the lives of all of those people on the airplane in their hands, the aviation industry has developed a checklist that pilots go through. One of the things they do in that checklist is they introduce themselves to one another, because they don't necessarily always fly together and they don't necessarily know who their co-pilot is and what have you. And they go through a checklist. And, you know, the aviation industry is one of the most safety-conscious industries in the world. And they have developed, because of human error that has resulted in the tragic loss of many, many people, they have developed these procedures. It's incredible to me as a layperson that our healthcare system in our surgical settings, for example, haven't developed the same level of structural, regulatory safety. And that's what the surgical checklist is intended to do. And in fact, I think many of its features are brought in from aviation, from the aviation industry. But so let me tell you, in terms of what's going to happen to patients in the OR, in the intensive care unit, on the wards, patient safety and quality is a concern for every profession. It's a concern of the Department of Health, and it's something that we are working really hard to beef up and make sure that we enforce and promote. And so our models of care, I can assure members, are not, will not take us down a road to put patients' lives in jeopardy or have them in any form of danger, and I would reject that characterization.
The honourable member for Yarmouth.
Thank you, Madam Chair. And I just wanted to reiterate that these are concerns brought forward in my district to me from healthcare professionals in the field that feel that perhaps we've moved too far in terms of in an acute setting, putting nurses in those situations that might be spread too thin, and that might feel that their ability to provide the service that's required, you know, is perhaps might not be sufficient in certain cases. So, because these concerns were brought to me by professionals in the healthcare field, you know, I strongly urge the minister, while tracking, you know, the developments of this model, that we pay particular attention to the you know, to the patient care outcomes and to what our nurses on the ground are saying about this model, and how comfortable they are with it, and how they believe the level of efficiency is with it. So I think it's all I can say is it's very important from my perspective to track those things and to continue to include and engage those vital healthcare workers that we have out there in the field in a meaningful, continual dialogue about these changes to ensure that it is doing what it's intended to do. And I'll, you know, if I do have these concerns that are brought forward to me, I will, you know, commit to the minister, Madam Chair, to share those with her via the House or via any other avenue we have to communicate. I thank the minister again for time and answering my questions, and And I'm sure this we'll be able to have this conversation again in the House or outside at some point. Thank you very much, Madam Chair. I'm going to pass the time along to my colleague.
The honourable member for Halifax Clayton Park.
Thank you very much, Madam Chair. And I had intended to share this hour with my colleague from Yarmouth. And kind of unfortunately, the answers have been very, very thorough and very detailed and somewhat long. And so I'm going to ask the minister, when I do get back up after we have our late debate, if we could be focused in our questions a little bit and our answers. I'll try to be focused if she will too, because it's just that the time is going to elapse for estimates and we have so many areas to explore. And right now I have only 5 minutes left in this hour, so I'm going to just raise a couple of issues because the minister, probably you may get to say a few words about this when we come back. But the minister has told us, and I'm pleased to see that she is chair of the Federal, Provincial, Territorial Health Ministers Committee, and that you meet on a regular basis. And in fact, if Nova Scotia is the chair and our Minister of Health is the chair, that you can help to set the agenda for those meetings and determine what should be on them. And I had the opportunity to read something just recently around food and wellness, and I know the minister's looking at an obesity strategy. This actually was a newsletter that comes out from the Centre for Science in the Public Interest, and I know that the minister is interested in science in this. They're talking about things like additives to foods that are known to increase hyperactivity with the ADHD, artificial dyes that are in foods, and they're asking that the government should have those either eliminated completely or very well marked on labeling. They're talking about sodium content. They're talking about trans fats, and I remember that the Speaker of this House brought in a bill as a private member probably in about 2004, calling for our government to do something about trans fats. And I realize whenever we talk about any of the labeling or food additives, we're a very small market with less than 1 million people in Nova Scotia, and we're not going to have a great influence on Kraft or any of the big food companies out there, Nestle's and whoever else owns all of the big food companies. And a lot of the food that people consume these days are, and it's probably unfortunate for our health, a lot of them are processed and refined, and we're buying canned foods and foods that have been prepared for us, and they have a lot of additives in them. And this one quick newsletter referred to, and I thought, the link to ADHD, where we have so many children on medications and a cost to the system, a cost to their parents, a cost to the education system, and really difficult times for those young people who are dealing with attention deficit. And we're medicating them, and I think a lot of times if we could look at their food that they're eating, we could have a big impact. And I know families actually and parents who are very, very cautious and work hard to control the food their children eat, and that does control that condition that their children have, at least to a degree. It controls it. So I'm asking whether that is something that we could have on the public agenda, and I think that together the health ministers from across the province could have, would have the muscle and the strength to lobby the health minister of the country. This newsletter, do I have just a couple of minutes? Yeah, this newsletter, which I said is just a note from that organization, actually refers to a Globe and Mail article that said that the Minister of Health had decommissioned a sodium group that was studying sodium in food, and that was in early December, it said, which prevented the group from pressing the government to implement its sodium reduction strategy. The minister, and this is the federal government we're talking about here, that the federal government Minister of Health had decommissioned that group. The minister also bowed to food industry pressure to weaken its sodium targets, the paper noted. And I mean, with the sodium, we know it's very closely linked to stroke particularly. And I think it is some of the Scandinavian countries had reduced sodium content in their food 20 years ago, and they have seen a marked decrease in the number of strokes. I mean, it's exactly linear. You can map this. And so why we wouldn't wouldn't be doing that to try and save ourselves, you know, the cost and the suffering related to that. And it just seems to me we don't have a federal government that's moving very, very strongly on any of this. We know we have a big food lobby, and we have health ministers from across the province, or not our province, but across the country, that are at this moment led by Nova Scotia, that perhaps we could put these issues squarely on the agenda as well. And the trans fats would be one, the sodium content, which I just said, and it appears that we've lost ground on that. And again, another one would be the severe allergies that people have to nuts and shellfish and some other products. And this article was saying that we have no regulations to make bold warnings on products that contain that. It may be in the label. You may have to search in the fine print, but they're saying, why wouldn't we make those very bold warnings so that people who have these conditions could get, you know, proper warning and will have fewer anaphylactic issues. And I think our time is elapsed for the moment. Thank you.
Thank you. The time allotted to the official opposition has expired. It's my understanding that it is the prerogative of the minister if there was a request for a response at this point. Okay. The Honourable Minister of Health and Wellness.
I would just say to the member that absolutely she raises a good point, and it's one that has been on the agenda of the federal, provincial, territorial ministers, particularly the sodium working group. Provinces aren't real happy. We will continue to push for that. And I'd love to see a copy of the material, and I'd be happy to take this forward to the FPT group. No.
The Honourable Member for Argyll.
Thank you very much, Madam Chair. Pleasure to stand for a few moments. I believe that we're going to have our hour interruption at 6 o'clock as per normal, so that gives me about 12 minutes to ask a few questions, and I know I'll probably get one or two in before time will expire. Before we meet. Yeah, I think I'll get one question in by knowing how it works here tonight. Now, I neglected to do something last week, or when I was speaking the last time, and that was to basically acknowledge the good staff that are in the House today. Of course, Linda Penny, who is our numbers person. I know the work that she does is absolutely phenomenal. So Linda, thank you for all your hard work again this year, and of course for your support for your minister. Kevin McNamara, our deputy minister. Pleasure to see Kevin again. I did have the opportunity to work with Kevin when he was CEO of the South Shore District Health Authority. And I know he did phenomenal work for them, and I know he'll be a phenomenal deputy minister for the Department of Health as well. So welcome to them, and I know there's probably a whole bunch of people up behind me that I can't see providing support, but I do welcome them to the legislature, and I'm sorry I neglected to say anything last time. I just got quickly into my questions. Madam Chair, I'm going to move a little bit to basically back to maybe where the member for Yarmouth was, talking about Yarmouth, talking about the ER services, and in particular, maybe when it comes to the doctor shortage that we are experiencing in that area. Here's the challenge, and I'm going to, number of weeks ago, almost 2 months ago, I was in Cape Breton, and I was going to a meeting in Albert Bridge, and not paying attention to where I was walking, and I think I was probably paying more attention to my BlackBerry or to my iPhone. I didn't have the right shoes on for the conditions. It was snowing a little icy, and I fell down on my right foot and sprained it. Luckily I didn't break it, but I'm sure I did. I heard it pop. I'm sure something popped. Maybe it was just something shaking loose in my head. Madam Chair, so luckily some folks that were at the meeting decided they didn't really have to listen to the meeting, that they would bring me to the Cape Breton Regional and have my leg looked at by the attending physician, and maybe a couple x-rays, make sure that I hadn't broke it. Now when we got there, the emergency room was full. But I can say that I was triaged quickly, given my number, my name, everything was taken at that point. We sort of found a little spot to squeeze the wheelchair in that I was sitting in at the time, and wait for some time. Now, my experience in an emergency room in Yarmouth is that I probably would have been there 8 hours or more because, of course, I wasn't hurting too bad. I couldn't walk on my foot, but it wasn't hurting, and I wasn't bleeding, and I wasn't having a heart attack, and I wasn't having any breathing distress. So I figured I'm toast here for a number of hours. So one of the nurses come out and basically comes and get this. I'm just trying to remember for Yarmouth. Get this. The nurse comes out and apologizes. She said, you know, we're sorry for the backup that's happening here at the hospital. All the other ERs are closed at this time, and everybody is here at the regional hospital. And what we're going to do in order to get people through is we're going to call in another doctor, and we should have people moving in a decent amount of time. Madam Chair, within 2 hours, I had been through triage, I had my x-ray, I saw my doctor, or the attending doctor, my leg was strapped up, I was sent home, well, not home, but over to the Delta where we were staying that evening. I couldn't believe it. Within 2 hours, I had seen a physician, been triaged off, everything was done. And I just, in compared to what I normally would have dealt with in Yarmouth, was phenomenal. So, my question is, how can we get the ER in Cape Breton moved down to Yarmouth, or how do we get the Yarmouth one to work like the one in Cape Breton? And we'll probably have part two.
The Honourable Minister of Health and Wellness.
Thank you very much, Mr. Chair, or Madam Chair. As the member was talking, I turned to the deputy and said, our directives are working. This is great. Because, you know, after Dr. Ross gave us his report, one of the first things that I said was, you know, why is it that Walmart can communicate better with people, or when I go out to the Department of Motor Vehicles to get my license renewed or my vehicle renewed, why is it that I have a better idea of how long I'm going to be there and what's going on than when I go into an emergency room? It makes me crazy. And in the last year and a half, I've been in our hospital's emergency rooms with someone who's been a patient. So I know how frustrating it is, and it's wonderful. I'm really pleased to hear that, you know, so we sent a directive to CEOs and we asked them to do some work on the customer service piece, to start thinking about better communication with people in the waiting rooms of emergency departments. If people have to wait, we need to communicate. And that doesn't mean a sign on the wall. That does not mean, you know, some little neon thing telling you how triage works. It means taking time to communicate with people. And, you know, and elderly people in particular, we need to let them know where the services are, where the bathrooms are, that they can go and they're not going to lose their spot if their name is called, you know, all of those things. We just need to use better common sense customer relations practices in our ERs. So now with respect to Cape Breton, I'm not sure why you're questioning how we can get that service happening in Cape Breton. Cape Breton, you were in Cape Breton when it happened. Got it. Okay. Cape Breton have done a tremendous amount to improve the flow through their emergency department. They set up a rapid assessment process on their own without additional resources from the department, and it made a huge difference in a very short period of time. And it improved the quality of job satisfaction of physicians and nurses and others who work in that department. And prior to doing that, they were very, very disheartened and demoralized.
Order,
and we were
please.
losing.
I'm sorry to interrupt the Honourable Minister, but we are approaching the moment of interruption. I would ask for consideration that we now recess for a couple of moments so staff can leave and to resume Committee of the Whole immediately following late debate.